Well, hello, everyone. Thank you so much for joining us this evening. Very excited to have my friend and colleague with us this evening. My name is Elise Fosnight. I am a PA in sexual medicine. I have a private practice in Asheville, North Carolina, the Fosnight Center for Sexual Health. Kristen is a pelvic floor physical therapist, and her and I have known each other for way too many years now at this point. And she actually, we get to work alongside each other every single day. So she is a part of the practice as well. And just so excited to have her speak on the role of pelvic PT tonight for those that have Peyronie's disease. Kristen, if you would like to take just a quick moment and introduce yourself, and then we'll jump into the program.
Yeah. As Elise said, I'm a pelvic floor physical therapist. I've got my doctorate in physical therapy. I have been in the practice of physical therapy now for about 8 years. And I've been in pelvic health for just about that whole time. The last 2 years of my practice being at the Fosnight Center with Elise, doing primarily sexual medicine, treating kind of all genders, gender care and all of the things of that nature. So been in and around the realm of public health for some time now, and located here in Asheville, North Carolina. And, I'm really excited to have this opportunity to talk to all of you tonight. I think it's not often enough that PTs kind of get in front of our fellow providers out there and have an opportunity to really talk about like what we do and how we can, support your patients. So I'm super excited to be talking about how we can help with Peyronie's in particular tonight. So thank you all for being here. Super stoked to just be talking in front of y'all.
Awesome, Kristen. Well, just a reminder, please use the chat function for questions, or if you want to give some praise to any kind of topic or things that we talk about, we would love to see that interaction there in that chat box feature. By all means, too, please use the Q&A for those questions and answers. Also, I will try to keep up with that. If we feel like it's really important for those questions to be answered in the moment, I will make sure that I kind of stop Kristen and we do that at that point. However, we'll probably move on and we're going to save about 10 or 15 minutes for questions and answers at the end of this hour. So Kristen, if you will go ahead and share your PowerPoint, we will go ahead and get started.
Get this pulled up. All right. Are we seeing that?
Looks good.
Cool. Sweet. Okay. All right, guys. So we'll kind of dive on in here, folks. As like I said, we're talking about kind of the role of physical therapy in the treatment of Peyronie's, working with this particular population. So we're going to kind of go into a variety of different topics tonight and, kind of talking about all right, there we go. I'm going to talk through a few just kind of hopefully review kind of topics as far as anatomy, things like that are really relevant to this area in particular. When we're talking about Peyronie's and we're talking about, sort of these connective tissue difficulties and the aspects of those plaques and how those plaques are integrated in with, some of these relevant anatomical structures. I'm going to give you guys a little bit of information about physical therapy as far as post-procedural education and how, physical therapists can really be a supplement to you all as providers for those at-home activities, those, home programs that y'all are giving them post-procedure, as well as then the scope of physical therapy interventions, whether in a post-procedural capacity or just in, here's how we work with penis owners as physical therapists. Because one of the things in both sort of in practice, but also in preparation for today, there is honestly very little research on Peyronie's and physical therapy, right? There's just not a lot that's looking at it because obviously the treatment of Peyronie's as it is is something that needs to be treated from a medical standpoint. PTs are not going to change a plaque in a patient's penis. But there's a lot that we can do to help supplement that treatment that you all are doing that I have found in my clinical practice and, in working with Elise, just seeing the improvements that we can get with the addition of physical therapy for the treatment of this population. So we're going to be talking about the scope of PT interventions and what that looks like. And then a little bit at the end, I just want to give you all some tips and tricks on like, where do I find a PT? And how do I vet that PT? Like, how do I make sure that the PT that I'm sending my patients to is somebody that is going to be able to help my patients, right? Somebody that's going to have the skill set and the knowledge to be able to work with particularly penis owners and particularly those that have Peyronies, because you'll find that in the realm of pelvic PTs, not all are created equal, as with any other provider out there in the medical field. So I want to help give y'all a little bit of direction on like, how do I find these people? Where do I go? How do I find somebody that's actually going to be really helpful for my patients in particular? So, all right. So to kind of kick us off here a little bit with relevant sort of pelvic anatomy. So when we're talking about, Peyronies and we're thinking about, that the plaque and how these plaques are formed, and knowing that, typically there's some sort of injury that is sort of initiating this process, it's creating this, and thinking not only about that plaque, but also about all of those other relevant tissues and all of those other, muscles and fascia and all of the things that are also going to be affected either through perhaps whatever that injury was, but also throughout the disease state of Peyronie's and how that's going to progress with patients. So obviously pelvic floor muscles is a big one. When you talk into a PT, I'm going to be talking about muscles. I'm going to be talking about bones and joints and all of those things. So pelvic floor muscles is obviously something that, as PTs, we're working in and around a lot. And so just being really mindful, in particular, when we're talking about the pelvic floor muscles, thinking about those superficial muscle layers. So that picture there on the left-hand side, you're going to see sort of the, bulbospongiosis, that ischiocavernosus over here to the side, and thinking about how those superficial muscles are going to have a part to play in the function of the penis. So particularly when we're talking about things like erections, and while with Peyronie's, we may not necessarily see erectile dysfunction, at least from a physical standpoint, we can certainly be mindful about the way that those muscles are functioning and how that's going to be affected if we have a curvature, and thinking about where that curvature is that creating shortening in these muscles? Is it creating just tension in these muscles? Are your patients having some sort of tension simply because they're stressed out about the disease state, right? So thinking about the impact of what those muscles might be doing and how that's affecting sort of this overall process. Maybe perhaps not the plaque in and of itself, but all of those secondary things that are going to follow behind that, right? And then in particular, thinking through the shaft of the penis, thinking particularly about the fascia. And so we have the superficial fascia that's going to sort of be just underneath the skin and sort of surrounding all of these structures. And that superficial fascia is something that we can definitely have an impact on from the standpoint of soft tissue mobilization, which I'm definitely going to go into a little bit later in the presentation. But being mindful of how, with these tissues, if they aren't getting stretched because say during that erectile phase, these patients are having this curvature, that curvature is going to create shortening in all of these structures. And depending on the length of time through which the patient perhaps has had that deformity or had that curvature, they may be looking at, years or decades. Apologies for my dog in the background. Decades even for some of these folks, where those structures have never been stretched to their fullest capacity. And so thinking about the impact that that's going to have on the fascia and all of these underlying structures. And then looking at in that picture, kind of in the sort of middle or over to the right here a little bit, we have this sort of cross section. And so thinking about that deep fascia of the penis and how that deep fascia sort of surrounding the cavernosal tissue, surrounding that corpus spongiosum, and how that again is also going to be potentially affected, and the ways in which those structures, even after we say release that plaque, whether through some sort of surgical intervention or injection or medication therapy or traction or something of that nature, there may still be a significant amount of shortening and a significant amount of restriction that's happening in some of these deep fascial structures that may need to be addressed. So again, we're going to be talking a little bit more about intervention kind of as we move through, but want you to kind of have, again, just a little bit of a review, kind of thinking about some of these structures as we're moving through.
And Kristen, I definitely want to draw attention to folks, right? We see this, like, when you look at that cross section, it's that deep fascial layer, right? And definitely there's a lot of overlap with that tunica albuginea, which is where that plaque is going to form up. So there could definitely be some overlap within that fascial structures, just some surrounding inflammation that's going to pull on that. So again, super important for us to understand all of these structures as well.
Yeah, absolutely. Absolutely. And so thinking about the shortening of those structures, but also post-intervention, right? If you're performing some sort of intervention, the effect that, like she said, that inflammation, potentially scar tissue development, if you're doing surgery, something of that nature, and the long-term implications of those things as well. Okay. So to kind of get into a little bit interventionally, but thinking a little bit more about how there might be options as far as, like, you know, post-intervention from your standpoint, right? So a post-procedural, say, whether that be something like an injection or traction therapy or post-surgical, you know, PTs can really be helpful in continuing that process of education, right? So, you know, for some things like, say, Xiaflex injection, if you're doing that, the modeling and straightening education, what I've certainly learned in working with patients is that they hear that education the first time and they're like, yeah, I think I got it. Totally makes sense. And then when you ask them, well, all right, so go ahead and show me that modeling technique or explain to me how that straightening technique works, they are oftentimes just not able to, you know, follow through on that, or maybe they're not doing it quite right. So the great thing about physical therapy is, you know, we're seeing your patients potentially like once a week, or at least for a handful of visits. And we have the opportunity to kind of continue that education and ensure that your patients are doing what they're supposed to be doing and doing it correctly, right? So that they're getting the fullest benefit from that intervention that you guys have performed, right? Other things to think about are, you know, if you're doing traction therapies with your patients, you know, PTs can be a great follow-up with that to make sure that they're following through with it, helping with adjustments in different cases, or making sure that they understand what they're doing, but also talking them through additional ways to kind of help support those therapies as they're working through things at home. It can also be helpful with compliance because they've got somebody that they're accountable to even more often than perhaps you guys as providers as well. And then post-operatively. So certainly if you have someone with a severe enough, you know, plaque that you're going to do some sort of a surgical intervention, then, you know, PTs can be super, super helpful with managing that post-operative scar tissue and pain for sure, as well as then supporting return to sexual activity, right? So I know, you know, PTs, we love ADLs. We love talking about, well, how can we figure out how to do these things, right? So let's talk position, let's talk limitations, let's talk about all of the different ways that we need to sort of problem solve, you know, what may be going on or how things are changing or what's happening. And so, I know a lot of times you guys as providers may not have the time to process through all of those things in your office, or you may not have the capabilities to kind of talk through positions and talk through, stretches and talk through ways to kind of work back into that. And so PTs are going to be a great option for you guys to be able to say, hey, let's work through this. And I know for myself, at least, I love doing partner education. Like, let's get partners involved in this. Let's talk about that so that we can kind of bring everybody together and make sure that everybody understands what your limitations are, what you can be doing, what things are safe to be doing, what does that progression look like? And just ensuring that, again, they're following through on the protocols that you have set forth for them, and ensuring that, as your PTs know, like, what are the protocols, when can they do these things, when can't they do these things, and ensuring that then, like I said, patients are compliant, that they're following through. So PTs are going to be a big part of a part of your team, and being able to help with that piece, right, and helping patients kind of move through that.
Kristen, I know you're talking about post-intervention. When we think about pre-intervention, I know you and I are both very much all on like prevention, proactive, what are the things we can do? And you and I really need to sit down and do a lot of, of research. And
yes.
Lord have mercy. Because I think that we really very much underutilize PTs in the Peyronie's disease, treatment therapy modalities. When it comes to pre-interventions, I think that this goes nicely with the question that we have from Jacqueline of like, with the pelvic muscles being shortening, are there symptoms that you've heard of being reported? And if there are potential for us to start to lengthen those muscles prior to injection or oral medications or surgical interventions, again, we're all about optimizing the results and functionality for these patients. So, for me, I see a huge role in PT pre-intervention as well. Do you find it helpful for you to see that patient pre-intervention so you know what you're working with?
Yes, absolutely, for sure. And that was kind of where I was going as we start talking about other interventions too. So you were right where I was going, guys. So with any of these kinds of things, the opportunity for me as a PT to see that patient prior to intervention is going to make it so much easier for me to know, like, first off, if everything's great as far as their pelvic floor and their other structures and all of these things, like, cool, awesome, then hey, I have a great baseline. More often than not, what I run into and what I've seen clinically is, unfortunately, that's not the case, right? So, and like I touched on before, if these folks have had this going on for a while, there's typically some anxiety around it, right? They may have ED, and it may be more of like a performance anxiety kind of situation, or they may be having issues with pain, whether it's related to the Peyronie's or it might be related to just pelvic floor muscle tightness, right? So they could have pain. They could have symptoms. I've seen tight pelvic floor muscles present as like prostatitis type symptoms. I mean, I see that all the time. These like what looks like these like resistant prostatitis or these chronic prostatitis, and they have these super tight pelvic floors that are creating all of those same sorts of symptoms. They may be complaining of things like constipation or straining with bowel movements, where they're having a lot of difficulty kind of just passing things in that nature. So there's definitely going to be these clusters of symptoms that you're going to hear from folks. And having that pre-assessment can make a world of difference for these people too, because if you're able to address those sorts of things ahead of time and start them on the path of relaxing their pelvic floor, or potentially strengthening their pelvic floor. Maybe they have a weak pelvic floor and we need to strengthen. Looking at these structures, right? Because there are things that we can start from a manual therapy intervention standpoint, or even self-mobilization standpoint, to start working on fascial mobility, to start working on muscle mobility, and absolutely address a lot of these things ahead of time. And if we're able to do that, it's only going to then improve the intervention outcome, right? It's only going to make what you do even more effective, because now we're taking away other variables, right? We're taking away any other things that are going on, so that when you address that plaque directly, now we're able to address just the plaque, and we don't have all of these other things that are continuing to be a problem. Because I will say, often that, I see folks post intervention that didn't have any idea that they had holding in their pelvic floor before. And they're like, oh my God, I had no idea that that could even be a thing that I was doing all of this time. And had I known, like, maybe I wouldn't be where I am now. Maybe I wouldn't have this post-procedural pain. Maybe I wouldn't have blah, 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 on down the list. So absolutely having that like prehab visit, can make a world of difference. And I think this is one of the things we as PTs are like, this is the one thing where orthos are like, everybody gets a knee replacement, gets PT before they get that knee replacement, right? Or your hip replacement or your whatever it is. But we tend to not think about that when we look at things like general surgeries or pelvic surgeries or something where we're affecting the organs, because we're like, well, they probably don't need it. It's not the same. They don't need to do the things. I see a lot of times where they really, really could benefit from having, if nothing else, a little bit of education, right? A little bit of knowledge on the patient's part can make a huge difference for them in just understanding what's going on afterwards too. So yeah.
Sure. Awesome. Yeah. Thanks, Kristen. And then just optimization of blood flow too, right? We know bringing in oxygen rich blood flow and the healing process and how that can help with those interventions too, can again, optimize, especially like recovery afterwards too, I think is super key also. So awesome. All right. I'll let you go on.
All right. Okay. So to dive into some interventions a little bit more specifically. So like I said, we were looking at things from the standpoint of this prehab, this post intervention, and just in general. So to kind of go through like the various kind of ways that PT kind of do intervention. So the low hanging fruit here, guys, is Kegels, right, folks? It's Kegels is what everybody thinks of, right? They think pelvic floor and they think, well, let's do some Kegels. And in some situations, Kegels are the answer, right? If the patient has weakness, yeah, let's strengthen. Let's get those pelvic floor muscles working more optimally. Let's improve the blood flow through hypertrophy of muscles. Let's get all of this stuff going in the right direction. So we have some great research for things like erectile dysfunction and looking at ED and the effects of pelvic floor muscle training and all of those kinds of things. And so it only stands to reason that if we're dealing with any sort of weakness or decrease in muscle tone or decrease in blood flow, that this can be a really great way to help with that. The biggest problem that I run into with Kegels is that they're often prescribed just for everything, right? And so the downside of that is if the patient already has overactive pelvic floor muscles and we're not adequately checking, then we might just be making things worse, right? So if we're having patients do strengthening and they're already holding a little bit of tension in their pelvic floor, we might increase pain symptoms, we might increase urgency symptoms, we might increase any number of things that they're kind of facing. So proper assessment is really, really important. And this is, again, where your PTs can be really helpful, right? Because this is what we do all the time, is we work with these muscles. And so we're able to do those assessments and help ensure that patients are getting the right intervention, but that they're coordinating those muscle layers appropriately to get the contraction the way that they need to, right? So we have all of these muscle layers. We've got our superficial, our intermediate, and our deep layer of muscle. And how we contract those muscles is going to be different, right? Those deep pelvic floor muscles are going to be those lifters. They're supporting our organs. They're ensuring that everything is being held up in our body. Whereas those superficial muscles are our squeezers, or in the case of penises, they can help bob the penis up and down, or sort of draw the penis sort of into the body. And those various cues are going to be helpful for initiating the control of those various muscle layers. And they're going to be helpful in improving how that overall coordination and contraction is working, right? So ensuring that not only we're assessing, but also that we're ensuring that they're doing it correctly. I think this is the number one thing I run into with patients who are weak, is that they're doing Kegels wrong. So even if they do need them and they need to be doing Kegels to strengthen, they're not coordinated and they're not getting the right muscles to activate at the right time.
Kristen, we have a question about how can you tell if those pelvic muscles are high tone or if they're weak?
So with high tone, and so this is a lot of times this is going to be something that you're going to feel on that internal assessment, right? So your high tone muscles and are going to be, if you insert that digit rectally, those high tone folks are the ones that you're like, you can't even get your finger in there, or once it is in there, you feel like you have a tourniquet on. Those are probably going to be your high tone folks, right? And even if you ask them to take a deep breath, or you try to cue them to let go, or you try to cue them to relax a little bit, you're going to feel like just nothing's happening and they just can't quite get there. And the hard part here is if you ask them to contract, it may still not feel like they're doing a whole lot, right? It might feel like there's still very little movement that's happening. And so that can sometimes kind of lead you astray. But with your folks who have sort of that lower tone or that weaker pelvic floor, you're probably going to feel less of that tightness. You're still going to feel those sphincters. Hopefully, if they have good sphincter control, you're still going to feel that internal and external sphincter activation. But as you're sort of feeling those muscles internally, it's going to feel a little bit softer. So one of the ways that I educate my patients, and this may be helpful for you all too, when I'm feeling pelvic floor muscles. So if you put your index finger and your thumb together and you sort of feel that part of your hand, right? So you're going to feel how there's a little bit of tension there, but it's relatively soft, right? So pelvic floor muscles at rest are never like fully relaxed, right? They always have a little bit of tone going on. So those deeper pelvic floor muscles should feel sort of like that. Now, as you move through your fingers, it's going to feel harder and harder and harder. Okay. So if you're feeling somebody's pelvic floor and it's feeling like pinky and thumb are touching each other, that's some overactive pelvic floor muscles, right? Those muscles are holding, and those muscles are in more of that, like, this is some problematic tension realm versus, oh, okay, maybe they're a little tight because my finger's in their butt and they don't like it, right? That's also the hard part here too. Y'all are probably like, yeah, nobody enjoys this. So that is a trick here, but that's one of my strategies that I have found really helpful when I'm assessing tone. And when I'm helping patients understand what their tone is feeling like too, that can be really helpful. And even if you're doing an external palpation, like if you're just kind of feeling around sits bones, that same idea can kind of apply there as well, as you're just sort of feeling on those musculature. So hopefully that little trick helps. I think that's been one that's really helpful for me in kind of assessing that pelvic floor tone.
Yeah. And I think even palpating around the base of the penis too, like the bulbo, those ischial, muscles too, I think can be really helpful. Also, just a thorough assessment.
For sure.
Yeah. Of that. Yeah. And you're talking about doing a rectal exam for these patients when you talk about internal. I just want to clarify that for everybody too. And can you talk about your positioning when you have them, when you do an assessment?
Yeah. So for my assessments, to be honest, I can do them in all kinds of positions. I would say, traditionally when PTs are taught to do internal assessment, a lot of us are taught to do it in side lying. And side lying is great, but in side lying, you're going to get skewed tone, right? One side's going to feel a little tighter than the other, just simply because of the positioning and the way that hip joint is pushing into the table, and the other hip is be hanging down unless you've really got it supported well. So a lot of times I prefer to do my assessments in prone. I'll get my patients, lying down with a pillow under their hips so that they're, flexed just a little bit. And I like to do my assessments in that position if the patient's comfortable with that, right? So if they're cool with laying on their belly and letting me kind of do my assessment there, that just helps to equalize the tone, or give me a more symmetrical sort of assessment when I'm assessing those folks. Because again, it takes that kind of hip component out, and having their hips flex just a little, it kind of puts their back into a nice comfortable position. And most of the time they're able to relax a little bit more. And that, again, for me, it helps me to, because I can do, a little bit of pressure on their sacrum if I need to assess that. I can assess coccyx really nicely in that position too, and I can kind of see what's kind of going on there. It also just gives me a lot more freedom of movement when I'm in that position to be able to assess both sides without having to do a lot of things. So I prefer that, but I've also done assessments in like a child's pose position or quadruped, if that feels comfortable for folks, depending on what I'm looking for. So, honestly, I think it's really all about, what's going to give you the best access and what's going to give you the most information.
Yeah. And I think that for a lot of us on the medical side, we've been taught to check prostates with them standing up and bending over. And I can't tell you how many locked down glutes and trying to
Right.
even find their
Right.
image is a part of it. So taking a lot of that tension out and having just more mobility, again, obviously if it's safe and comfortable for the patient. So awesome. Thank you.
Yeah, absolutely. Absolutely. Okay. So to kind of go to the other side of our intervention here, so moving away from strengthening and now thinking a little bit more about relaxation and sort of down training. So what do we do if they have really tight pelvic floor muscles? What are we going to do about that? So for me, probably the first thing that I start folks with when I find somebody that has really tight pelvic floor muscles is going to be diaphragmatic breathing. So diaphragmatic breathing is something that is really helpful, not only from the standpoint of, this kind of relaxation of the pelvic floor, but we're also going to be working on their nervous system a little bit. We're going to be, aiding in just mobility through their thoracic spine, through their sacrum, through their hips potentially. And we're just kind of opening up all of these spaces within their body, right? So diaphragmatic breathing, also people call it belly breathing. People will call it yoga breathing. I do that in yoga all the time, right? If they're doing yoga. This population, maybe not as often am I finding them doing yoga, but some of them do. And so when we're talking about diaphragmatic breathing, and this is a great technique, I think, even for all of you, even if just in your office, to help patients if they are a little bit anxious or they are, feeling a little locked down or something like that. This could be a great technique to just help sort of calm folks down while they're sitting in your office or just kind of talking to you through an assessment. So diaphragmatic breathing, we're getting that nice contraction of the diaphragm down. And so as the diaphragm contracts and our lungs fill up, we have to sort of release the abdomen and we have to sort of release the pelvic floor muscles, which naturally sort of happens as we breathe in, right? So as we inhale, that sort of piston comes down through the diaphragm, belly releases, pelvic floor releases. So we can take that further by sort of intentionally sending that breath down into the pelvis and into the pelvic floor, as well as the abdomen, right? That lower belly, even through the upper abdomen, depending on where their restrictions are sort of located. So breathing is probably number one this is day one homework for anybody who has sort of tight pelvic floor. We're going to definitely then follow that up with stretching, right? And I'm going to then incorporate that breath into their stretching routines. So we're going to be working on pelvic openers, such as things like, that knees, like wide sort of knees to chest, what we call like a happy baby, or something like a child's pose position, if you're sort of familiar with that, what that is in yoga. But things where we're sort of flexing the knees up towards the chest, but we're also getting some nice external rotation. So we're opening up the pelvis, we're opening up the hips. I would, this population, and I would say just like penis owners in general, we tend to see perhaps a little bit less flexibility or a little bit more, mindfulness around flexibility. So, ensuring that we're getting good lumbar mobility, we're getting good hip mobility, we're stretching hamstrings and quads, and we're stretching the lower abdomen, and we're kind of getting just general movement going for these folks. So that we're being really intentional about how we're moving the body and we're opening up all of these external spaces, in addition to the pelvic floor. I also do a lot of mindfulness training. So one of the big things with folks who are holders of their pelvic floor muscles, I would say that by and large, a lot of them don't necessarily realize that they're holding that tension. And so when we first start working into this, unless they are having symptoms, because some of them aren't necessarily having like daily pain, or maybe they have a little bit of occasional constipation, or they have a little bit of this. But if you asked them point blank, they probably wouldn't be able to tell you, yeah, I'm totally clenching my pelvic floor all the time. Most of them would probably say, no, I don't think I do that. So getting to a place where they can attune to that part of their body and be very mindful and aware of what their pelvic floor is doing, because we can't really release it unless we're able to pay attention to it, right? So once they get to that place, then we can definitely do. And there's a lot of really wonderful research out there about mindfulness in chronic pain and mindfulness in sexual function, at least in women, or cis females. And so lots of really good stuff out there as far as mindfulness. And like I said, if they can't tune into it, they can't release it. So that's sort of step one. And then behavioral modification, figuring out where their stresses are coming from, what their anxieties are about, activity modification. Are they over exercising? Do we need to supplement with more stretching? Do we need to get away from CrossFit for a little while? Do we need to, take a moment away from weightlifting, something of that nature, so that we can sort of gauge like, all right, what do we need to change and how can we change that? And how can we maybe use some of these strategies to help us manage those kinds of things in our life as well?
Kristen, we have a question about, and I'm guessing in this patient population, what do you see more common? More of those high tone pelvic floors or more weak pelvic floors?
I would say probably more of the high tone side, especially if it's something that's been going on for some time. In more acute cases of Peyronie's, like it may not be as much that we see as much of those sorts of changes, but certainly folks that have been dealing with this for years or even decades, they spend so much time worrying about their pelvis, worrying about their penis function, worrying about how it's working, why it's not working, what's going on, and until they get to a point where they actually are getting some sort of intervention. So I would say the anxiety of that, and just even potentially trauma, right? Depending on what the trauma was that set this off, or what the injury may have been that sort of set off this cascade anyway. So I would say the majority of the time they're more of like a higher tone. They're holding some tension, whether that's a psycho-emotional thing or a physical thing, or both, or all of the above. I would say a lot of times that's all of the above, bio, psychosocial. We're bringing it all around. So I would say typically it's going to be on the higher tone or muscle holding side for sure.
Yeah, and that's exactly what I see too. And in general, with any kind of pelvic genital concern in the more cis male population, I'm seeing a lot more holding patterns and things like that, for sure. And then too, when you talk about the mindfulness piece of it, some patients, some penis owners have this whole dissociation right between their genitals because they've avoided it, like this avoidance. So now having to like tune into your body, understand your body, breathe, see what's happening with your muscles. This is process. So again, I think another reason why it's so important to get to kickstart the whole treatment process with these types of interventions before there's an actual medication injection procedure, more, at the site, intervention too, I think is super helpful.
Yeah, yeah, for sure. Okay. So manual therapy. So the sort of hands-on part of what I do as a PT, but also what I teach patients to do, right? So the big thing for me too is empowering my patients to also take what they learn from me and then continuing it at home. So muscle releases, right? So trigger point release, soft tissue mobilization, strumming, sustained holds, a whole variety of things that we can do from that standpoint. This can be done internally via some sort of rectal, digital rectal work in that respect. Doing like trigger point releases or strumming or some sort of mobilization there. I also do a lot of work teaching patients how to use tools at home. So in this situation, if we were doing internal releases, I might have them get like a pelvic wand. They're typically like S-shaped. And so those can be a really helpful tool to help them then do some of these like self trigger point releases at home. They also make things like dilators that you can use rectally and things like that if we are getting into a place of like, significant tension holding in those kinds of capacities. But in this population, I would say something like a pelvic wand might be a little bit more helpful. And there's some that even have like vibration, which can be really helpful. And especially when we're talking about things like blood flow, like vibration can be wonderful, both in imparting that relaxation, but also helping to promote blood flow to the area, right? And some of these things can be used, like I said, internally, but some of them can also be used externally, right? Can be used with sensation. So if we are having, tight pelvic floor muscles in particular, we can see everything from changes in blood flow, changes in sensation, right? So if you think about it, if they're not getting blood flow, like the tissues aren't getting blood flow, their nerves aren't getting blood flow either. So we can see decreases in sensation or increases in sensation, for the good, the bad, and the ugly, because of the way that that tissue is being restricted by these muscles just holding so much tension. So being able to do some release to that, typically done in conjunction with breath work and all of those kinds of things to help promote that trigger point release, but also through, external means, right? Trigger point release to the external muscles, doing any sort of interventions such as like dry needling. So myself as a PT, I can do dry needling and I have the education to do pelvic floor dry needling. So that's an intervention that I'm able to use. Not every PT gets trained in dry needling. So again, something to kind of look at if you're really like thinking that dry needling is something that you really want for your patients. There's some great evidence for dry needling to be helpful with various things from like ED and sort of muscle releases and helping blood flow. But it's also a wonderful way when you're looking at, kind of as a slight aside here, but Elise and I in our practice, we use it as a great way to determine like if patients are going to respond to something like a muscle injection, right? So dry needling is a great way for us to sort of see like, all right, let's see how they respond to dry needling. And so dry needling, for those of you who aren't necessarily familiar with it, we use needles that are very much like acupuncture needles. So they're kind of in the same vein as what acupuncture needles are going to be like. But in opposition to acupuncture. So acupuncture is thinking about energy and chi and the flow of those kinds of things. With trigger point dry needling, we're essentially identifying a trigger point in a muscle, and then we take our needle and we put it directly into that trigger point, in the hopes that we're going to, essentially sort of reset that muscle. And so it's going to work sort of on that dorsal horn ganglion. It's going to help, from the standpoint of that spinal cord input, and just reduce that like danger signal that's essentially being sent to that muscle that is creating this holding pattern. I had one instructor describe it as like taking jumper cables to the muscle, and sort of shocking it out of its sort of tight state. And so dry needling can be really effective, and it's a much quicker intervention, right? It's 30 seconds worth of needling, versus something that might take me, minutes to kind of work on from a trigger point, manual trigger points space. And particularly for patients who don't tolerate rectal work, like internal rectal work well. Again, dry needling is much faster. So if they're like, I just can't do this internal soft tissue stuff that you're doing, we can go in and we can needle, and that needling session might take 2 minutes, where it might take me 10 or 15 minutes to get the same sort of effect when I'm working just with my hands, right?
Kristen, when you're talking about the dry needling or the trigger points in this manual therapy, do you find that there are specific muscles more involved that are like commonly involved across the board? Or again, is this pretty individualized with like specific muscles, again, like ischio, bulbo, some of those deeper?
Yeah. So in particular for penis owners, I think in general, we find depending a little bit on the diagnosis and kind of what we're working on. Again, with Peyronies, it could be kind of anywhere, could be kind of all over, because there isn't necessarily like a specific muscle function or a specific muscle that's being kind of targeted here. When we look at things like ED or something of that nature, ischiocavernosus and bulbospongiosis, those are going to be your go-tos for sure. So if your patient is having something of that nature, where they are having some sort of ED issues in conjunction with, but certainly thinking about, again, depending on where the plaque is located, you might be getting some involvement into those superficial pelvic floor muscles. And so probably those superficial pelvic floor muscles, you're going to see a really good benefit or a really nice bang for your buck, especially if we're talking about muscle function. But I would say in this population, there could be just as much of those like deeper pelvic floor muscle involvement here as well. Yeah.
Gotcha. Awesome. Thank you.
Yeah, for sure. So then to kind of keep on rolling here, myofascial release. So fascia. So we talked about that fascia early on, that superficial and that deep fascia of the penis, but also just thinking about like the lower abdomen, right? All of like that superficial fascia is going to be kind of contiguous with the fascia from the lower abdomen coming down towards the genitals. Also just the fascia along like inner thighs, right? Thinking about kind of over the front of the hips through that inguinal region. Thinking about how that fascia is going to kind of interplay all in through there. But one of the things, that I have found really helpful is like direct penile intervention. And this is again where, finding PTs that are willing to work directly with penises is going to be really important for this population. Because I actually will go in and I will teach patients how to do like skin rolling techniques, where you're sort of like grabbing that skin and you're rolling it along, right? And so we're doing direct kind of fascial intervention to the shaft of the penis, right? And so we're teaching them how to do this skin rolling technique. A lot of times in clinic, we're working obviously with like a flaccid penis, unless you have the benefit of working in an office where someone can create an erection for you, which we have done in our office, which is great. So say Elise is doing an assessment, and then I can kind of follow up, and we can actually kind of work with erect penile tissue, which is great, because for a lot of times for patients, we're teaching them these techniques in office. I'm teaching, on their, sort of flaccid penis, but at home, I'm having them do these interventions when they have a spontaneous erection or something of that nature, where they're actually working with that tissue when it is on a little bit of stretch, right? Because that's when it's going to be really effective, when we have sort of some stretch on the rest of the tissue. And then we can really work a little bit more directly on those fascial restrictions where they are along the shaft, and where that plaque is, or where that plaque was, depending on kind of where they're at as far as their treatment process. Obviously within the confines of where they are in their treatment. Like, we don't want to be doing things, if you have recently injected or doing other kinds of interventions, but in and around those times. And obviously, like Elise and I've been saying, prevention is key. So an ounce of like prehab here can make a big difference when you do those interventions later, because if you've kind of broken up some of that other tissue, it may really help that intervention be more successful for the patient, or they might start to see changes a little bit faster.
Right. Yeah. And I think that really goes into then the other type of intervention that you do. And I apologize if you have this later in your slides, but we do have a question specifically like on modeling, right? Because, that's one of the things too. I utilize my pelvic PT for a lot. So especially when we do like Xiaflex injections, where that's part of like their therapy, is to start doing the modeling, which is the straightening and the stretching exercises. So rather than having them come back to either see me, right, it's a billing issue, right? I own my own practice, and listen, counting pennies here. We want to make sure we can charge for everything. So utilization of a PT for that modeling is going to be super key. And again, more of that involvement where we're taking a much more broader, holistic approach to it. It's not just, okay, stretch it for 30 seconds, bend it for 30 seconds, and then you're done. There's so much more that's actually involved with it. And then adding the skin rolling technique along with it, I think is super helpful. Kristen, is there like a specific description on how you talk to your patients about that modeling procedure with the stretching and the straightening?
I mean, a lot of it's probably going to mirror a lot of the education that you guys have, just following, and especially if you are doing something like Xiaflex, I know they have a very specific, like, okay, you're going to do this 3 times a day, and you're going to do this 1 time a day, only with a spontaneous erection, don't elicit an erection, and doing all the things. So certainly mirroring all of that same language that you guys are hopefully most likely going to be using with your patients as well. But just, like I said, for me, really, getting the patient to doing it correctly. And I think one of the things for me too, again, as a PT, I'm seeing them more often. So we're checking in more often. So we can get that, like, okay, you're holding that tip of the penis, you're bending, you're getting that stretch over that site, not going into pain, but we're keeping, that 30 seconds of stretch. We're working on that, mobility of that space. And then in that moment too, for me, and, maybe this is a little bit of a variation, but again, when you're thinking about that fascial mobility, I might have them do, like, as you're doing that bending, you're creating a little bit of stretch. So maybe we're using the thumbs, and we're doing a little bit of like I'm pulling my thumbs apart just a little bit. So we're stretching the fascia sort of around that tissue, right? So we're creating a little bit of that. So as we're holding that 30 seconds, we might be slowly kind of drifting those thumbs apart from each other. So we're creating a little bit more of a stretch kind of through those tissues. And then, with the straightening, when they're doing that, that once a day, again, just doing that as you're intended to do it, holding, again, keeping out of that pain space, avoiding any additional injuries. And just, again, anytime that we can add in some sort of additional intervention there, with those in more of that like straightening phase, we might be doing a little bit of skin rolling while they have that erection. So that, again, we're working with those tissues when they're on a little bit of tension naturally, right? Because that's going to help that be a little bit more effective for those folks.
Right. And then at the same time, right, because what I get when I have taught this before I had a utilization of PTs is then they hold, right? They're holding their breath and then we're
Right.
holding tension. And I'm like, no, we can't do that. So blending a lot of these breathing exercises that you did in the very beginning
Mhm.
along with this, I think that you get better stretch, you get more mobility. Like again, we're not holding again so much tension back in there. And
Mhm.
it's all about training. So and then obviously, is that again, kind of that same approach to when you're talking about the strumming piece of it. And then for those that aren't maybe familiar with strumming, just maybe explain just a little bit about what that means.
Yeah, so strumming is more of like a muscle technique. So when we think about muscles, you can do like a trigger point release where you're sort of like holding a sustained on a spot that's maybe tender or on a spot that is tight and you're just sort of holding. And there's various ways of looking at that. So they're like, okay, well, you hold like 30 to 60 seconds at tissue like tolerance, like pain level tolerance or what have you, or you hold 90 seconds at just tissue resistance, but not going into pain, because we don't necessarily want to create a bunch of ischemia. So that's one of the things with patients, like don't hold your trigger points for 5 minutes. It's not going to do you any good. It's probably going to hurt you. But strumming is going to be more of like that, like a stroking maneuver, right? And so in the pelvic floor, we're thinking about like the way that those muscles are sort of a bowl. And so as they're working with those muscles, we're thinking a little bit more about like we're strumming along those muscles, right? So I'm elongating along the fibers as much as possible. With patients, where the intervention here, if we're teaching them how to use like a wand, we're going to talk them through that as best we can. Obviously, the wand can't give them the same kind of feedback. So the wand can't be like, yes, you're going along the fibers. But if we can give them as much feedback, and this is where, I do my interventions and then I teach them in the office how to use the wand. I don't just say, go get this and try it out. I make them bring it to the office and they use it in office with me the first time so that there aren't questions later, right? I don't want them to go home and try to use something and be very confused and then come back later and be like, that was the worst thing I've ever done. So I really, really, really strive to make sure that patients understand any and all interventions that I'm giving them. So especially when it comes to things like wands or dilators or whatever it is we're working with, they're using it with me before they're using it at home. So we make sure that they know this is how it felt when Kristen did what she did. This is how it feels with the wand. Okay, that feels like what she was doing. Now I can do that at home and feel confident with it.
Yeah, exactly. Awesome.
Cool. Okay, so to kind of move outside the pelvis a little bit. So we've talked about this a little bit earlier on where we were talking about hips and we're talking about hip mobility, spinal mobility, hip mobility. All of these things are also going to be really important, like I said, for this population. And so on this slide, I've got a couple of photos here, just to kind of reiterate again, the hip and pelvic floor connection and just the way that, we have that obturator internus muscle kind of down here in that lower photo. You can really see that nice like internal obturator internus photo and just where that's living, right? And that pelvic floor sits right on top of that obturator internus. I mean, they're just married to each other. And so when we're thinking about pelvic floor function, we kind of have to think about what is that hip doing? Does this patient have some hip OA? Does this patient have, some sort of other pathology going on? Is there tightness in that obturator internus muscle? Do I need to be addressing trigger points there? Do I need to be kind of considering what piriformis is doing, right? So piriformis is another muscle that's kind of in and out of the pelvis. And, piriformis gets a bad rap in a lot of ways and gets blamed for a lot of things. But it is right there, again, right next door to the pelvic floor. So really thinking about what are your hip rotators doing? What kind of strengthening are you doing? What kind of exercise are you doing? Are you doing some stretching for these muscles? Are you doing a lot of strengthening? Or are you not doing a lot of strengthening? Are you super weak in your hips? You know, my runners and cyclists are notorious for not doing good cross training. And so they oftentimes have these like weak hips or hip dysfunction that can lead to all kinds of other issues. So ensuring that we're really also just kind of checking out all of these other things. In addition to that, things like bony alignment, you know, making sure that like, are your pelvic bones lined up? Do we have an innominate rotation or a sacral torsion that's happening? You know, do we need to make sure that we're addressing those things as well? Because those can obviously present as, you know, back pain or hip pain or any number of things. But if you have an innominate rotation or you have a sacral torsion, it's going to affect your pelvic floor. It's going to put weird stresses on those muscles, and it's going to create tensions in weird areas, or it's going to create potentially like nerve restriction or nerve entrapment somewhere, or some sort of nerve root irritation that can create nerve pain or other kinds of issues. So just ensuring that we're also getting a well-rounded sort of picture of what's going on outside of the pelvis is going to be really beneficial for these folks as well. Okay. And then this last slide, as far as intervention goes, these are things that are not necessarily you know, as supported by the, you know, evidence-wise, there's very limited or sort of conflicting evidence, but these are interventions that PTs can also do. They may not be used for Peyronie's as often. Things like laser therapy and iontophoresis. So these are things that are within the scope of PT practice. These are things that we can do, and, you know, potentially help sort of supplement, again, what you guys are doing. Or if you are someone who is going to use iontophoresis, I don't know if this is really used a whole lot in practice anymore. I'm getting the sense not, as well as I was looking through some of the research and things, but those are things that PTs are able to do as well. And then from the standpoint of pelvic floor muscle dysfunction, you know, biofeedback. I'm sure many of you are familiar, at least to some extent, with biofeedback and what that is, what that looks like. So biofeedback can be really helpful. You know, I find it most helpful when we're talking about down training. That said, you know, I tend to use my like bioprobe because I like to know, you know, qualitative information about what my pelvis, you know, my patient's pelvises are doing, not just quantitative. And so drawback that I see with biofeedback is just that, you know, it just tells me something is squeezing or something is relaxing or something's doing something, right? But it doesn't tell me where, it doesn't tell me what, and it doesn't tell me how. So I think biofeedback has its place. As a practitioner, I can't say it's my number one go-to, but it can be really great. And there's some wonderful evidence, especially for down training and kind of looking at it from that standpoint. And if a patient truly is just like, I can't get it, like, I can't do it. I can't figure out how to use my pelvic floor. I can't do it. Biofeedback can be really helpful for those folks. Sometimes they need to play the Angry Birds with their pelvic floor to be able to figure out how that works, right? And there are wonderful apps out there for folks to use at home, between the PeriFits and your Kegels, you know, all of these different things that are out there nowadays. That can be really helpful for folks too. So, you know, I do think it definitely has its place, and I think it's really helpful for a lot of folks.
Yeah, and I think that answers one of the questions that we had to Kristen, was about those efficacy of those devices for pelvic floor exercising, you know, that work around the anus when it comes to that electrical, you know, impulse. And then those recommended apps. Do you, and I can't believe I don't really know this, but do you know anyone specific for, again, penis owners that have an anal insertion versus like a vaginal insertion? I don't even know if there are any.
I don't know. I mean, some of them are shaped such that they do have a bit of like a bulbous kind of shape. So you could probably use them. I don't know if there are any that are designed specifically for, as far as like the at-home devices. So like in clinic devices, yes. I mean, they make them that are a little bit smaller, but they have the tab, like nice little flange on the end, and things of that nature. But as far as those home devices, I don't know that there is, unfortunately.
Right. Yeah. And I know that
even think about that.
Yeah, I know. Nobody take that idea from us now.
Right.
Yeah. Or if you do, please incorporate us in that. Yeah.
Yeah.
But no, and even thinking about the electrical pads, right? There's ones to devices that, right, we can just put them
External.
around external, pads, whatever
Yeah.
else. So
Yeah.
again, I'm not familiar if actually those have any apps with those either.
I mean, some of them are convertible. So, I mean, if it's something that you can kind of like plug into and maybe use with the devices, again, the external pads are great. Unfortunately, they're gonna pick up primarily like the sphincter musculature. You're gonna get some of that, like deeper muscles too, but the thing that I run into is there's just so much crosstalk. And so, depending on what's working and what's not. And again, I just wish you could get more information out of it. And there's no correlation between like numbers and strength and like, oh, I reached 20 milliamps. Well, what does that mean? Nothing. You're stronger than you were last time, but I can't actually, it doesn't correlate to a grade of muscle strength in any way, shape, or form. So I think that's one of the other things too, is it's just hard because we can look at it from the standpoint of like, how is this one patient progressing from visit to visit? But it doesn't give us any like real like information as far as like, what is your strength? I don't know.
Yeah, right. Yeah, exactly. So awesome. Thank you.
Okay, so to kind of bring this all to a close, and just to kind of give you all some information. So where do I find a PT and how do I make sure that this PT that I find is somebody who's going to be able to work with this population, right? So where are we looking? So APTA is the American Physical Therapy Association. So they have a pelvic health section. And I will, once we get out of here, I'll drop the like links to these into the chat, so y'all can have those too. So APTA pelvic health section, pelvic rehab is another resource. And so that one I know is pelvicrehab.com. And that one's run by Herman and Wallace. So Herman and Wallace is one of the big educators out there as far as like pelvic floor education, particularly for PTs and OTs, but I've certainly taken classes with PAs. I've taken classes with nurse practitioners. I've taken classes with, a number of advanced practitioners that, just want to get more knowledge on like pelvic floor and how to work with pelvic floors and all those kinds of things. And the other is Global Pelvic Health Alliance directory. And this is through Pelvic Guru. So Pelvic Guru has been around for some time, and they recently sort of created in the last few years this like Global Pelvic Health Alliance sort of membership. And in doing this, they created this really wonderful directory that has like global directory, right? So we're getting people from all across the globe. And you're going to find everything from PTs, docs, fitness pros. I mean, anybody and everybody that works with the pelvis, you're going to get good information from there. So you find a PT in your area, but you want to know like, what are they doing, right? Because like I said, not all pelvic PTs are created the same. A lot of folks get into this game and they're like, I'm going to work with cis women and I'm just going to treat pregnancy and I'm going to treat incontinence, which is great. Happy for them. But when you're looking for a PT for Peyronies, you want to find somebody who works with penises. So you want to ask those PTs, like, do you work with people with penises, right? Are you willing to see somebody, who's going to need more than just internal work or more than just biofeedback or more than just, simple interventions, and then making sure that they know a little bit about Peyronie's. Like, what do you know about it? Do you know anything about it? Do you have any information? Can you do some research about it, or figure that out? Or lastly, do you perform interventions directly to the penis? Because even then, there are plenty of PTs out there who say they work with penis owners and yeah, totally, I'll see all of your men. But then they don't do any interventions directly to the penis, right? And so this is again, one of those drawbacks with certain PTs, because I'm like, you have to find somebody who's willing to, work with those genitals to be able to work with these structures, and then also just feel comfortable and help normalize it for the patient, right? Because it's awkward. It can be, right? If you've got a relatively young female working with your penis, like it might be awkward. But you know what, if I go into that experience and I'm like, nope, yeah, this is what we're going to do today, it's going to be great, this is going to help your penis so much, and I treat their penis like I treat their knee, right? It's a body part to me. People hold a lot in their genitals, and it is a very like sacred thing for some of them, and it definitely is something to be handled as like, this is a sensitive part of your body. I don't want to disrespect that, but for me, it's a body part. It's a body part. And so entering into that interaction as I'm working with your body part, helps to really normalize that for the patient and makes it feel a little less weird for them. But like I said, when you're working on finding those PTs, make sure you're asking the hard questions, because if they don't, then probably they're not the PT for you. So
well, and I think too, Kristen, as medical providers too, it's really important for us to disclose that information ahead of time. When we say, hey, I'm going to send you over to a pelvic PT, and oh, by the way, they are completely trained to touch and assess your genitals. They're not right. They're not going to like walk in like, oh my goodness, you didn't tell me that they were going to do a pelvic exam on me also. So I think that that's a really big, like, set them up for success by letting them know too, that that's a possibility that they could, evaluate that too. And I know you do this too, but you always give your patients an option, right? Especially until you gain trust and you have more conversations with them. You don't always have to do an internal exam on that first visit, right? It's just a lot of assessment.
Yeah. I mean, the great thing about PT is I'm gonna see them a lot more often than y'all are, right? I'm gonna see them once a week. So if we spend that first visit assessing their spine and assessing their hips and assessing their pelvic alignment and looking at all of those external things, and we build a little bit of trust, and then perhaps the next time they come in, they're like, okay, yeah, I'm ready. Let's go ahead and let's look at all those other things, because we have the time, we have the ability to take the time to kind of build up to that and kind of work into it and build that relationship and build that trust, in a way that you guys just don't. Medical providers don't have that time. You don't have that luxury of seeing people over and over and over again because your schedules are full, or you just don't have the ability to fit that into a 15-minute follow-up, right? So lean into your PTs for that, because that we love it. And I'm all about it. So
Well, awesome. I think is this your last slide?
yes.
Awesome. Cool. Well, we have, like, throughout this presentation too, we've answered all of the questions that have come up. I don't really see any other questions at the moment. So I know we ran over a little bit. Thank you all so much for staying with us.
Thanks for sticking it out.
Kristen and I could talk about this for hours on end. So I hope now that you recognize the importance of pelvic PT in general when it comes to pelvic health, but specifically for Peyronie's disease as well. And there's so many overlapping conditions that go along with it, with that as well. I was going to say that we've got one more question, but it's a thank you. So we really appreciate, again, you all being here. We have so much fun with this and really just enjoy working together. So just like Kristen said, please lean in on your PTs. I think they're so valuable, very underutilized. And take the time to really pull on them and collaborate with them, because your patients are going to love that. And we see really good optimization of improvement for that too. So awesome. We'll continue to join us for more of our SMSNA AAPA webinars. We've got oh my goodness, I think we have one more coming up. So please join us for that as well. And hopefully we will see some of you at the SMSNA conference in Miami at the end of October. Everybody have a good evening, and we will all see you soon. Thanks.
Thanks, everyone. Good night.